Imagine a world where your very first breath isn't guaranteed. Pharmacist. Today, we journey into one of the most delicate battles in medicine, apnea of prematurity. Let's explore the science, the care, and the future of breathing together. Apnea of prematurity, or AOP, disease of premature babies, is when a newborn, born too early, simply forgets to breathe for more than 20 seconds. It's one of the most common challenges faced by infants born before 28 weeks of gestation. Why? Because their little brains are still immature, specifically the brainstem, so since they are still under construction, the brain cannot function properly, and the signal from brain to lungs isn't steady yet, like a flickering light in a storm, so the brain cannot give a mature order to the brain, and the lung cannot do its work easily and steady. There are three phases to apnea. Central apnea, no signal, no effort. Obstructive apnea. The effort is there, but something blocks the airway. And mixed apnea, where both occur together. To treat apnea, we have non-pharmacological treatment and pharmacological treatment. Non-pharmacologic management. 1. Prone and head elevated positioning. Prone position along with head elevated tilt position showed reduction in apnea and bradycardia. 2. Continuous positive airway pressure, CPAP. CPAP at 4 to 6 centimeters H2O has proven to be a safe and effective therapy of apnea of prematurity. It is effective in obstructive AP rather than central apnea. 3. Flow through nasal cannula. Both high and low flow through nasal cannula can be a useful adjunct therapy in some infants with apnea who are already receiving methylxanthines. 4. Synchronized nasal ventilation. Nasal intermittent positive pressure ventilation, NIPPV. It's said to be more effective than CPAP in preventing extubation failure. As for the pharmacological treatment, caffeine. Caffeine isn't just for sleepy college students. It's a lifesaver in a NICU, stimulating the respiratory center, increasing breathing drive, and reducing apnea episodes by almost 50%. Give caffeine in doses. Loading dose, 20 milligrams per kilogram. Maintenance dose, 5 milligrams per kilogram daily. But how does caffeine work? Caffeine mechanism of action. 1. Central nervous system, CNS, stimulation. Main mechanism. Caffeine antagonizes adenosine receptors, specifically A1 and A2A receptors in the brain. Result. Adenosine normally promotes sleepiness and suppresses neural activity. By blocking adenosine, caffeine increases neuronal firing, leading to enhanced respiratory drive and wakefulness. White heavy checkmark in AOP, apnea of prematurity. This stimulation helps immature respiratory centers in the brain maintain regular breathing patterns. 2. Enhancement of diaphragmatic contractility. Mechanism. Caffeine increases intracellular cyclic AMP, CAMP, by inhibiting phosphodiesterase, PD. Result. Elevated CAMP improves calcium availability in muscle fibers. Diaphragm muscles contract stronger and more efficiently, helping the neonate breathe better. White heavy checkmark in AOP. Stronger diaphragm, better breathing efforts, fewer apneic episodes. 3. Increased sensitivity to CO2. Mechanism. Caffeine enhances the brain's response to carbon dioxide, CO2, levels. Result. Normally, rising CO2 levels stimulate breathing. In preemies, this response is weak. Caffeine restores this sensitivity, making babies breathe deeper and faster when CO2 rises. White heavy checkmark in AOP. Better CO2 sensing, more consistent breathing. 4. Mild bronchodilation. Mechanism. By relaxing smooth muscles in the airways through CAMP increase. Result. Wider airways. Easier air movement. White heavy checkmark in AOP. Helps prevent obstructive components of apnea, especially in mixed apnea. Thank you.